Assalamu alaikum. Good afternoon, everyone. Today, my lecture will be speak about the minimally invasive mitral valve interventions. Introduction: minimally invasive mitral valve surgery does not refer to a single approach, but rather to a collection of new techniques and operation-specific technologies. These include enhanced visualizations and instrumentation system, as well as modified perfusion methods, all directed toward minimizing surgical trauma by reducing the incision size. This table shows the ideal mitral valve repair, show that small non-rib spring working incision, high definitive modified 3D incision, tactile feedback, minimized cardiopulmonary perfusion time, cardiac arrest time, blood product usage, and hospitalization, and high quality repair show that operative mortality less than 1% and no SAM or residual leak. We have absolute and relative contraindications to minimally invasive and robotic mitral valve surgery. The absolute contraindication show previous right thoracotomy, severe pulmonary dysfunctions, myocardial infarction or ischemic less than 30 days, coronary artery disease required coronary surgeries, severe generalized vascular disease, right ventricular dysfunctions, and significant aortic stenosis or insufficiency, severe mitral annular calcification, and significant bleeding disorder, and significant dilated aortic growth. On the other hand, in relative contraindications, previous stenotomy, moderate pulmonary dysfunctions, coronary artery disease requirement, and poor LV ejection fraction less than 50, pulmonary hypertension, and chest deformities. Pollution of minimally invasive mitral valve surgery. To perform the ideal cardiac valve operation, surgeon need to operate in restricted space, all the tiny incision which required assistant visions and advanced instrumentations. Although the ultimate goal of completely endoscopic mitral valve repair has not been widely achieved, so MIS has continued to evolve, with many surgeons performing procedures along the minimally invasive continuum, utilizing a variety of techniques, include either limited visions or video assistant or the direct operations. The term minimally invasive or limited access cardiac surgery have suggested to reduce the size of the incisions, the avoidance of sternotomy, use of partial sternotomy or mini thoracotomy, or the need of cardiopulmonary bypass. We have 4 levels in minimally invasive surgery. Level 1 is direct visions, that the incisions is from 10 to 12 centimeters. And level 2 is direct visions, is mini incisions between 4 to 6 centimeters. At level 3 is video directed and is called micro incisions between 1.2 to 4 centimeters. And level 4, it is small incisions less than 1.2 centimeters. So the type and size of the musculoskeletal incision remains central to discussion around the minimally invasive cardiac surgery. Merit of modified small sternal, parasternal, and mini thoracotomy incision are used to access the cardiac valves. Although many surgeons prefer the hemisternotomy approach, a right mini thoracotomy show excellent exposure of both direct visions and video thoracoscopic mitral valve access. To access the left atrium for direct vision using limited access mini thoracotomy, 4 to 6 centimeters submemory incision to place along the anterior axillary line, a small sections of pectoralis and intercostal muscle fiber are divided, and the apex is entered through the 4th intercostal space with minimal rib tractions, and no rib cutting. Minimally rib sparing to prevent intercostal nerve injury and use of intraoperative local anesthesia are the keys to minimize the post-operative discomfort. Show that the depictions on the left side that show that this is hemistenotomy used for minimally invasive mitral valve aortic surgery, and the patient to the left show the mini thoracotomy used for minimally invasive mitral valve surgery. This is the cross clamp will take about transthoracic clamping right mini thoracotomy through video access. The most severe and transseptal mitral valve approach, although sternotomy required a large cardio incision. For aortic mitral and tricuspid valve operation, some surgeons use sternotomy extended to the fourth intercostal with direct aortic arch and right atrial cannulations. To access the mitral valve, they extend the aortotomy from the right atrium cross the left atrial roof and continuing to divide the interarterial septum. Cannulation and carbon-pulmonary perfusion, all the perfusion canal are placed under the echocardiographer guidance using the Slending wire, guide wire techniques. Although 2 centimeters oblique incisions, bearing suture are placed in both femoral vessels near to the inguinal ligament. And the right femoral artery is cannulated, and for the inferior vena cava drainage, using either single or the dual stage, is passed into the right atrium. De-airing, the meticulous cardiac air remove is particularly important in minimally invasive valve operations. Difficult exit in manipulating and de-airing the cardiac index, as it cannot be elevated. Also, with right anterolateral mini thoracotomy, air tend to be retained along the dorsal oriented ventricular septum and in the right pulmonary veins. Moreover, this position places the right coronary ostium in the most exposed position to enter air. So continuous carbon dioxide inspirations has been particularly helpful in minimize the intracardiac air and should be being before the cardiac chambers are opened. Fusing CO2 continuously into the thoracic and try to cross clamp relative ventilate both lung to draw the gas deep into all the pulmonary veins. After aortotomy closures and following cross clamp release, suction is applied to the aortic root vent, and constant transesophageal echocardiographer monitoring is essential to ensure adequate air removal before weaning of cardiopulmonary bypass. Cross clamp for aortic occlusion were used transthoracic cross clamp. Some surgeons they are using into balloon for aortic closure. These are the transthoracic aortic clamp for minimally invasive mitral valve surgery. And this is the endoballoon aortic occlusion that inserted through the femoral artery by the echo guide wires retrograde to place the ascending aorta. Now, the right mini thoracotomy procedures. The indication, we have indications in case of combined mitral and tricuspid, any mitral valve lesion, mitral stenosis, or mitral regurg, any tricuspid valve disease, stenosis or regurg, some infected endocarditis cases when it is only involved one valve and abscess or required extensive reconstruction work. Atrial fibrillation ablations, all lesions can be finished through the same incisions. if ablation procedure can also be done as only procedure performed, and patient with secundum ASD and ASD premier or coronary sinus ASD that is difficult to be done percutaneous or patient usage. Contraindication, avoid in patient with moderate or severe aortic valve surgery, as myocardial protection become challenging, resulting in severe RV failure. Any patient with fixed pulmonary hypertension or significantly high pulmonary pressures, patient with cardiogenic shock due to ruptured papillary muscles, patient with previous thoracic surgery or adhesions developed from the previous surgery, patient with severe MAC. Surgical steps in right knee thoracotomy procedures, double lumen and check position with endoscopic, central routine, no subclavian and neck cannulation for both under ultrasound, patient positioning with 35 to 40 degrees, right side up and right axillary full expanded, fem bypass through small right groin incisions. Complication and preservation. The retrograde cardiopulmonary perfusion techniques always induce a risk of atheroembolic stroke, vena cava injury, femoral arterial complications, and retrograde aortic dissections. Careful preoperative vascular screening can minimize this problem. All cannula should be set using Schlendinger techniques under echocardiography. Leg ischemia during retrograde perfusion can be avoided. We place oxygen saturation monitoring patch on both legs with significant decrease in cannulated leg oxygen saturations, where we shunt from the cardiac mass arterial cannula into the dorsal femoral artery. The phrenic nerve injury can be caused by overstretching the pericardium, cautery injury, or direct instrumental injury. This is a major problem in patients with compromised pulmonary functions. Injury can be avoided by visualization of the nerve during instrumental insertion. Overstretching can be avoided by making the pericardium incision at least 3 centimeters ventral to the nerves. Unilateral pulmonary edema is a serious complication. So short perfusion time, systemic cooling, avoidance, or trauma, limited blood product transfusion, all they can decrease this risk. We also believe that low-level PEEP and frequent alveolar resectment while on cardiopulmonary bypass is beneficial. Left ventricular dysfunction is a serious problem and can be avoided or minimized by selected patients with ejection fraction no less than 40 to 50%. Systemic cooling goes to 28 degrees centigrade, and meticulous de-airing mandated to minimize the myocardial protections. Ventricular distension is a serious problem and can be prevented by leaving a ventricle vent after repair or replacement. And the right ventricular dysfunction can be minimized. Meticulous cardiac de-airing before weaning from the cardiopulmonary bypass is essential. And the right 30 chest elevated place right coronary artery ostium is performed position of the air embolism from the residual left ventricle. So the clinical outcome, a recent meta-analysis from the International Society of Minimally Invasive Cardiac Surgery show that versus conventional sternotomy, the MIS mitral operation has less post-operative atrial fibrillations, chest tube drainage, transfusions, and infections, where there was no difference in repair quality or freedom from the reoperative. Moreover, operative mortality was statistically difference 1%, 1.5% in commercial versus 1.2 in MIS. Other pressures include reduced intensive care time and length of hospitalization, as well as faster return to the normal activity. These advantages were despite significant longer perfusion and aortic cross-clamp times. Conversely, they found more stroke 1.2 in conventional groups comparing to 2% MIS. Aortic dissection omits same 0.2% in MIS, and the phrenic nerve injuries is 3% in MIS in the MIS groups. It's my reference, our reference, Lawrence, and thank you so much. And any question?
Thank you, Dr. Abdelaziz, for the presentation. Any question for Dr. Abdelaziz? Okay, so shall we start the next presentation or take a break for 5 minutes? Dr. Ziad?
Yes, I'm here.
Okay, we'll start.
Okay.
Okay, I think let's start the next presentation.
Okay, no problem.
Thank you, Dr. Ziad.
Assalamu alaikum جميعا. My name is Ziad Sharif. I am R2 resident at Medical City in King Saud University. Today I'll present to you the outcome of mitral valve repair. This is our objective. We'll start with introduction, then repair rate, hospital mortality, degenerative mitral regurgitation, the advantage of mitral valve repair, and gender difference. There is limited information on late outcome of mitral valve repair, but several retrospective clinic outcomes and study found that mitral valve repair improves survival. During past decade, 2/3 of our mitral valve repair is performed in asymptomatic or minimally symptomatic patient, and this is likely the case in most large referral centers. Mitral regurgitation is the most common valve disease in Western countries and expected to increase. In this slide, you can see the sample of this study, which is 18,147 patients. We will focus on mitral valve repair and its outcome. Here we can see the mean age is 66 years, plus minus 12, and 59% of the cases is male. Also, mitral valve repair represents 55% of all mitral valve surgery. Repair rate of all mitral valve surgery is 56%, and it's decreased with old age, female gender, and a higher Charlson comorbidity index. It's range from 65% in patient under 60 to 46% after age of 75 years. It's higher in males with 65% comparing to 43% in female. And in comorbidity index, it's 66% with index of 0, while it's lower as 39% in the patient with index of 2 and more. In summary, old age and female gender and higher comorbidity index inversely associated with mitral valve repair. Hospital mortality increased with age as 3.4% in patient under 60 years, compared to 10.3% after 75 years. It's also higher in patients who underwent replacement rather than repair and a combined rather than isolated surgery. The mean ICU duration were 17 plus minus 15 days, and the length of stay is 9 plus minus 12 days. Importantly, that is in hospital mortality of isolated mitral valve repair was only 1.1% versus 5.8% in isolated mitral valve replacement. In degenerative mitral regurgitation, which is the most common etiology, repair was significantly lower in patients who underwent combined versus isolated mitral valve surgery, and who underwent repair were younger and more frequently men and had lesser burden of comorbidity compared with replacement. Repair also decreased with increased burden of comorbidities, as 77% in patients with comorbidity index of 0, compared to 59% in patients with comorbidity index of 2 and more. Here we can see that degenerative mitral regurgitation has better 1-year rate of death or readmission for heart failure than secondary mitral regurgitation. And also isolated surgery has a better 1-year rate of death or readmission for heart failure than combined surgery. Here we can see that in hospital mortality according to the type of surgery and etiology is better in degenerative type and isolated surgery. Here's some of the main results to summarize. First, mitral valve surgery associated with hospital mortality increase with age, comorbidity index, replacement surgery, and combined surgery and etiology. Degenerative represents the main etiology leading to mitral valve surgery, and it is twice as secondary type. Operative mortality and 1-year rate of death and heart failure readmission were twice as high in secondary type as in degenerative type. Elderly and women were less likely to undergo mitral valve repair. In contrast, most patients with secondary type underwent replacement. The advantage of repair over replacement is well established. Mitral valve repair offer a lower operating mortality, a higher left ventricular ejection fraction preservation, a lower risk of stroke, infection, avoidance of anticoagulation, and overall a better long-term survival. Repair surgery rate also markedly decreased 60% when a combined procedure performed. When patients underwent a combined surgery, usually they are older or presented at higher index or more advanced disease. Whether this lower repair rate is related to surgeon preference or to anatomical difference could not be established. However, given the well-established benefit of repair versus replacement across all subsets, repair should be a choice of technique when the anatomy is suitable. Previous study shown that women were underdiagnosed, undertreated, and referred later than men for mitral valve surgery, which translated into an excess mortality risk compared with men. Two potential explanations can propose. First one is anatomical difference, and second one is gender-based bias. Regardless the reason, the lower rate of repair in women is a major concern deserving a specific correction action. In another study, out of 840 patients, there was a 4 early mortality and 179 late mortality. The cause mostly sudden death in addition to congestive heart failure, stroke, myocardial infarction, and anticoagulation-related hemorrhage. Here you can see that the leading cause of all mortality in this study is COPD, and the leading cause for reoperation or recurrence is isolated anterior leaflet prolapse. In this study, long-term survival patients with more advanced symptoms in New York Association Class 4 was below the expected survival for the general population match for age and sex. These findings support the recommendation for early surgical intervention in patients with asymptomatic severe mitral regurgitation and normal left ventricular function. Here we can see that New York Heart Association Class 4 was below the expected survival for the general population match for age and sex, with which is marked as red dot. 38 patients underwent repair mitral valve surgery. The indication was recurrence of mitral regurgitation or mitral stenosis or endocarditis. Investigators compared the outcome of 127 patients who had mitral valve repair with 127 treated conservatively and found that surgery had a survival advantage on asymptomatic patients with normal left ventricular ejection fraction and surgery also recommended for asymptomatic patient with impaired function. Although mild left ventricular dysfunction increase the risk of late cardiac mortality. The severity of mitral regurgitation plays an important role in development of adverse events such as congestive heart failure, AFib, and cardiac death in asymptomatic patients with mitral regurgitation. And pulmonary hypertension also predict adverse event in asymptomatic patient with mitral regurgitation. The last thing I will talk about that patient who had the mitral valve repair had a small but constant risk of thromboembolic event. The highest risk was during the first year after surgery, justifying the recommendation of oral anticoagulation during the first preoperative, post-operative month, and probably should be extended to 6 months or longer. AFib didn't have an independent effect on survival after mitral valve repair. Infective endocarditis was rare in the study, and only 9 patients out of 840 developed this complication. Unlike heart valve replacement, which is associated with risk of infective endocarditis early on after surgery, there was not any single event during the first year of follow-up in the study of mitral valve repair. These are my reference. You have any question, please? Thank you.
ايش انا ولا مره دي دكتور ممتاز.
Okay, thank you, Dr. Ziad. So we'll take a break, 10 minutes, and we will be back at 1:45 with Dr. Al-Anoud Al-Mhaysen. She will present Everest trial. Thank you again, Dr. Ziad. Okay, Dr. Al-Anud, are you ready?
Yes, Dr. Ahmed, ready.
You can start, please.
Thank you. Assalamu alaikum, everyone. Good afternoon. This is Al-Anud Mhaysan, R1 from KFSH and RC. Today, inshallah, I will talk about the Everest 2 trial. The Everest 2 trial is a randomized, controlled or clinical trial for the predictors of mitral valve replacement in de novo surgery or after the mitral clip procedure. As a beginning, in the patient undergoing surgery for mitral regurgitation, mitral repair has advantage over mitral replacement of improved durability, less anticoagulation, and better preservation of the left ventricular function. As mitral repair techniques have improved, some investigators have concluded that nearly all regurgitant mitral valves with degenerative disease can and should be repaired. However, a large population-based sample have shown that mitral valve repair rate, only 15% because of several factors. We will discuss them later on, inshallah. Everest, which stands for the Endovascular Valve Edge-to-Edge Repair Study, it's a prospective multi-center randomized controlled trial comparing percutaneous repair with the mitral clip device to the mitral valve surgery in the treatment of mitral regurgitation. The present study analyzed the patient's characteristic and treatment effect on mitral valve repair versus replacement. We can see in this picture the mitral clip device, which is one of the catheter-based or percutaneous method used to treat mitral regurg. The data from the Everest 2 trial were analyzed to meet four objectives. The first one, to determine whether the overall repair rate is comparable between patients who underwent the mitral clip procedure versus de novo surgery, to determine the specific baseline demographic or valve characteristic that are predictive of mitral valve replacement, to assess the mitral clip procedure effect on the ability to surgically repair the valve, to evaluate the effect of surgeon experience on the mitral valve replacement. Regarding the method of this study, after individual institutional review board approval, 279 patients were enrolled at 37 sites in North America and randomized 2-to-1, 184 for the mitral clip device and 95 to the surgery. In the Everest 2 trial, patients who with functional mitral regurg or degenerative MR involving anterior, posterior, or bileaflet disease were eligible for enrollment, and repair replacement surgery were considered acceptable outcome for the trial in the surgery group. Before randomization, the surgeon were asked to indicate whether the surgical mitral valve repair versus replacement was planned, a conversion of the overall repair rate between patients who underwent the mitral clip versus the de novo surgery was performed using a Fisher exact test, which is one of the statistical tests used to determine if there is a non-random association between two categorical factors. A specific baseline demographic or valve characteristic were assessed for association with mitral valve repair versus replacement on univariate analysis in multivariate logistic regression model, including anterior or bileaflet pathology, functional etiology of the MR, previous cardiac surgery, patient age, and the treatment group, whether it was in the mitral clip device or surgery group. 3 mitral clip patients who were not implanted with the device and did not undergo subsequent mitral valve surgery were excluded from the study. Mitral valve injury or difficulty in removing the mitral clip device was assessed by retrospectively reviewing the operative note to assess the surgeon experience. Surgeons were asked to provide the number of mitral valve repair and replacement performed in the year before the enrolling the patient in the Everest 2 trial. The baseline characteristic between the two groups were compared using the Fisher exact test for categorical variables and student t-test for continuous variable. Now we will come to the surgical result throughout the first year of the study in both two groups. As we said, we divided the patient into the mitral clip group, which we have 184 patients initially, and the surgery group, which consists of 95 patients initially. 6 of the mitral clip patients were not treated, as well as 15 of the surgery group. So now we have a total 178 in the mitral clip group and total of 80 patients in the surgery group. Starting with the mitral clip group, of them, 3 has no device, no subsequent surgery, and withdraw from the study. So the total number now is 175. Throughout the first year of those patients underwent mitral clip device placement, 37 of them underwent subsequent surgical either replacement or repair. 20 for the repair underwent post-device repair, and 17 underwent post-device replacement. For the surgical group, which is a total of 80 patients, 69 of them underwent repair, whereas 11 underwent mitral valve replacement. 2 of the patients enrolled to the repair has failed, and replacement was done for them. So the total number of the repair now is 67, and a replacement is 13. Now we will come to the predictors of the mitral valve repair versus replacement. The baseline characteristic of the mitral clip and the surgery groups, including age, functional etiology of the MR, previous cardiac surgery, anterior and bileaflet pathology, were not significantly different when all patients were combined or compared together, both in the mitral clip or percutaneous and surgical group. The only variable that showed a trend toward different between the two groups was anterior and bileaflet pathology on univariate analysis, with the patient undergoing replacement showing a trend toward a greater incidence of anterior or bileaflet pathology. The effect of mitral clip procedure on the ability to surgically repair the valve. Of the 37 patients who underwent surgery after the mitral clip procedure, 15 of them underwent replacement where repair was planned before randomization. 19 underwent repair as planned pre-procedurally. 2 underwent replacement as planned pre-procedurally. The remaining patient, which is 3% of them, underwent mitral valve repair when replacement was planned for them. For those, a valve injury was reported by surgeon in 11 of those patients. 6 cases were reported to be related to the mitral clip procedure itself. The remaining 5 were reported to be related to difficulty in removing the device during explantation. In 6 of the 11 cases in which mitral valve injury was reported, mitral valve repair was able to be performed as planned. However, in the 5 remaining cases, the surgeon chose to replace the valve. Of these 5 patients, 4 had previously been implanted with the 2 mitral clip devices. The remaining patient was not implanted with mitral clip devices. Replacement was performed in the 6, 33, 41, 52, and 54th days after the mitral clip procedure. The surgical repair rate in patients noted to have a mitral valve injury was not different from the remaining patient undergoing surgery after the mitral clip device. To compare the effect of the interval to surgery after mitral clip procedure, the repair rate of mitral clip patient undergoing surgery after 19 days of the placement of the device was compared with the repair rate in patient undergoing surgery within 90 days of the device placement. Now we will come to the 80 patients in the surgery group. 8 of them underwent replacement when repair was planned pre-procedurally. 67 underwent repair as planned pre-procedurally, and 5 underwent replacement after as planned pre-procedurally. For those 8 de novo surgery patients who underwent unplanned replacement, the reason for the replacement were recurrent MR requiring repeat operation in 2 of them, attempted repair but residual MR present intra-procedurally, advanced age in 1 of them, and bileaflet disease with myxomatous leaflet in 1 of the cases. Now we will come to the effect of surgeon experience on mitral valve replacement in center in which patient underwent mitral valve surgery after mitral clip procedure, which are a total of 37 patients. The surgeon had performed a mean of 62 mitral valve surgery, 40 repairs, and 22 replacement. In the year before participation in the Everest II trial, an average 16 mitral valve surgery, 38 repairs, and 22 replacement was performed in a center in which mitral clip patient underwent mitral valve repair in total of 20 cases. An average of 64 mitral valve surgery, 41 repairs, 23 replacement were performed in a center in which 17 mitral clip patients underwent mitral valve replacement. In the Center for the Surgery group, the mean number of mitral valve surgery performed in the year before the Everest 2 trial, it was 60, 39 repairs, 21 replacement in 67 de novo surgery patients who underwent mitral valve repair. It was 61, 39 repairs, 22 replacement, and 13 de novo surgery patients who underwent mitral valve replacement. On examining the de novo surgery and the surgery after mitral clip patient combined, there was no difference in surgeon experience when all patients who underwent mitral valve repair were compared with the patient who underwent mitral valve replacement. So as a conclusion of this trial, the Everest 2 trial provides unique data for the patient with surgical MR owing the prospective data collection and central echocardiographic core laboratory analysis. The data confirmed previously reported that anterior and bileaflet prolapse are associated with replacement versus repair, patient age, functional etiology of MR, and previous cardiac surgery, as well as the surgeon experience, and interval from the mitral clip procedure could not be confirmed as a risk factor for replacement in the present series. These data also shown that the one-year mitral repair rate after mitral clip treatment was similar to that of the de novo surgery. However, the multivariate analysis and the intraoperative findings suggest some increased likelihood of ultimate mitral valve replacement associated with mitral clip therapy. The lower surgical rate after the mitral clip replacement versus de novo surgery resulted in part from a valve failing after the mitral clip procedure had a greater prevalence of anterior and bileaflet pathology. However, in 5 of the 37 patients undergoing surgery after the device placement occurred after mitral valve injury associated with the procedure itself or the device explantation. Although the likelihood of undergoing mitral valve replacement instead of repair because of mitral clip therapy was not high, about 3%, some caution is warranted in patient selection for mitral clip therapy. Furthermore, because all patients with unsuccessful initial repair, either it was in the device group or the surgery group, did not ultimately return for surgery, it's impossible to know how many more unplanned replacements may have occurred in this cohort if subsequent operations were performed. Rogers and colleagues reported successful mitral valve repair up to 5 years after mitral clip placement, and the 5 patients requiring unanticipated mitral replacement after the mitral clip therapy all underwent surgery fewer than 60 days after the placement of the device. Surgical extraction of the mitral clip device from the mitral leaflet can be simple as lifting the device itself from the leaflet early after placement. However, after 13 days of the placement, the device will have some degree of surrounding fibrosis that might need surgical debridement along with opening the arms of the mitral clip device to facilitate explantation. Explanting the mitral clip device from the leaflet is facilitated by pulling the central lock harness of the mitral clip, thereby opening the grippers and the arms of the device. Increased surgical experience with removal technique will likely improve the ease of mitral repair after the removal of the device itself. So the Everest 2 data offers an important insight into the patient selection of the mitral clip therapy, the potential device therapy to reduce the likelihood of surgical repair would be of little concern of patients who have no surgical option or have a greater risk of surgical mortality or have a limited life expectancy. Patients who are surgical candidates with a high probability of surgical repair will have to weigh the safety advantage of percutaneous mitral clip therapy against the possibility of ultimately needing a mitral replacement instead of repairing because of the previous mitral clip device placement. In conclusion, using these data from Everest 2 trial, selected patients who have a high operative risk of surgical repair might be the most appropriate candidate for this device therapy at this early stage in the development of this novel technology. Additional follow-up will be elicited the long-term effect of the mitral clip placement on the mitral repairability. So this is the end of my presentation. If you have any question, you are more than welcome. Thank you for your listening.
Okay, thank you, Dr. Anoud. I think by this we will conclude our session for today. Dr. Ahmed case will be rescheduled for the next sessions. Thank you all.